Dr. Harry J. Heiman, Clinical Associate Professor in the Department of Behavioral Sciences in the School of Public Health at Georgia State University, for a discussion about the opportunities before us to address social determinants of health, or SDOH, and health equity. In addition to his role at GSU, Dr. Heiman is a fellow in the American Academy of Family Physicians with over 20 years of clinical practice experience. And from September 2012 to August 2013, he had the opportunity to serve as a Robert Wood Johnson Foundation Health Policy Fellow in Washington, D.C., where he served on the committee staff for the House Energy and Commerce Committee in the U.S. House of Representatives under Ranking Member Henry Waxman. During this one-hour webinar, Dr. Heiman will discuss social determinants of health through the lens of his experience as a primary care physician and expert in health policy. He'll speak briefly, and then we'll devote the rest of our time to your questions and his answers. We invite you to share your questions via the chat tool in WebEx. Please make sure to send them to everyone. And then we'll get to as many of those questions as we can. We'll also ask some of the questions from the registration forms. Just as a reminder, this event is being recorded, so please remember that as you type in the chat. And all of the participants, if we could go to the next slide, please. Just as a reminder, all of the participants are muted, but you can ask your questions and interact with us through the chat. So now I'm going to turn it over to Harry to share some of his thoughts on how public health can move upstream to address health equity and the social determinants of health. Welcome. Looks like we're having maybe just a tiny technical problem.
Okay, inevitably, regardless of how many times you try, there's one button that you can't quite see on the screen. So thank you so much for inviting me to join Eugene and colleagues from ABT, and very excited to have this conversation. Obviously, conversations look a little different on virtual platforms than they do in person. But I know we have about an hour together, and I was planning to spend maybe about half that time sharing some of my thoughts and insights and some of the evidence that I've been working with over the last 10, 12 years around opportunities to move upstream to advance health equity. And then really look forward to responding to some of your thoughts and questions. You know, as someone who's now been in academia for the last dozen years, I feel obligated to put my objectives out front for two reasons. One, because if you look at these and go, yeah, not really interested in that, it's your opportunity to hop off. But it's also your opportunity to keep me accountable. If I say that by the end of this, you're going to be able to discuss social determinants and their relevance to health equity, look at the opportunities to advance population health and health equity, bringing a health and all policies approach, and think about what it means to apply a health equity lens, you now have an opportunity to try to keep me accountable to that. So hopefully this is a familiar map to those of us in public health. It was a map put together by the father of epidemiology, John Snow. For those of you of a younger generation, not the winter's coming John Snow, but the original John Snow, who in response to the cholera epidemic in London in 1854, literally went house to house and made black marks indicating the cases. And it was through that geospatial analysis that he recognized that the Broad Street pump was the driver of that problem. We think of geospatial analysis as something very 21st century, but obviously public health is grounded in place, and public health is grounded on the impact of place and neighborhood context and neighborhood conditions on the opportunities people have both to live their lives and to have healthy lives. Something that public health, I would argue, has gotten away from, and I think we're now recognizing that it's time to return in meaningful ways to those roots. This may be also a familiar map looking at life expectancy at birth by census tract. So again, it's a relatively small unit of analysis. Just to orient you, the black color means that there's inadequate data. Red reflects a lower life expectancy between mid 50s and mid 70s in terms of years. And yellow represents a higher life expectancy between 81 and 97. If you take a look at this and you live as I do in the Southeast, the first thing that comes to mind is, well, maybe it's time to move, because there are clearly geographic differences and geographic variation. But the other thing that's striking about this is that if you were to blow it up, which I won't, you would notice that there are areas that are red right next to areas that are yellow. So in fact, within census tracts right next to one another, there are people that live very long and healthy lives and people who actually die prematurely. And what we've learned and what we'll be talking about is that most of those differences are very grounded in social determinants of health and the conditions in which people live. This is a map showing CDC's Social Vulnerability Index, which for those familiar uses about 15 different factors around social vulnerability, including poverty and employment, access to health care, level of educational attainment, food security or insecurity. And on this map, the areas that are blue show the greatest vulnerability, and the areas that are yellow show the lowest social vulnerability. If you think back to the previous map I showed you, significant overlap between those parts of the country and those areas. This is at the county level, showing the greatest social vulnerability, and those parts of the country that have the lowest life expectancy. Again, for those of us that have been looking at social determinants of health, not something that is surprising. There's a project at Virginia Commonwealth University called Close the Health Gaps, where they've looked at a number of major cities across the country and looked at differences in life expectancy from one neighborhood to another. This is Atlanta, where I live, and where maybe many others of you live. And you can see between Bankhead on the lower left and Buckhead in the middle towards the top, there's a 13-year mortality gap. This has been done in a number of cities, and it's not unusual to find between a 10 and 30-year gap in life expectancy in neighborhoods that are literally just several miles apart. I used to joke that you can't argue that the climate is different in Bankhead than it is in Buckhead, but actually you can, because a lot of studies are coming out now looking at urban heat islands and finding that in fact the built environment very much drives the way heat builds up based on a combination of how much concrete you have and what the tree canopy looks like. So in fact, in low income, impoverished, disproportionately Black and brown urban neighborhoods, you have a much greater likelihood of having heat islands than in more affluent neighborhoods. So even from a climate perspective, there are profound differences between different neighborhoods. And those differences between neighborhoods haven't occurred by chance. It's not by chance alone that people choose to live in certain parts of a city. We have a long history in the US of systemic and structural racism that has created racial zoning, and in the late 30s, a practice called redlining, where certain neighborhoods were literally redlined, or based on the code you can see in the bottom left, identified as, quote, hazardous, not based on any conditions in those neighborhoods other than the fact that the people that lived in those neighborhoods were primarily Black and or recent immigrants. And if you lived in a neighborhood that was marked as hazardous, that restricted your ability to receive loans for purchasing a home, for doing a home improvement, for starting a small business. And those are policies and structures that have been perpetuated leading up to the late 30s and since then. We've seen that COVID-19 in very predictable ways has disproportionately impacted many of the same communities that already experience significant health inequities in terms of other health problems like chronic diseases. And this is some mapping done by Biggs and colleagues looking at COVID incidents in New Orleans relative to the social vulnerability index that I shared earlier. And not surprisingly, there's a profound clustering of social vulnerability and higher likelihood of COVID. And again, that's something that we've seen across cities and communities in the US. So what do we know about determinants of health? If you ask the average person on the street, well, what's most important in terms of your health and in terms of your having a long, healthy life? Significant portion of people would respond to health care, clinical care, access to care, and having high quality care. And while studies have shown over the past decades that about 10 to 20% of what drives your health outcome is clinical care, in fact, it's a relatively minor health determinant. People also turn to health behaviors and like to talk about personal responsibility and whether people eat healthy foods or whether they smoke or use drugs. And while that's also important, the most important factor driving health outcomes are the social, economic, and physical environments in which people live. And not only that, it's those environments that drive health behaviors. It's those environments that create the context in which people make decisions about the foods they eat or whether or not it's safe to go outside and exercise. And it also impacts their access around clinical care, because in the same way that racial residential segregation has a profound impact on housing and on education and other factors, our access to healthcare and healthcare providers is also profoundly segregated in the US. So I suspect that most of you are familiar with social determinants of health. For those of you new to the language, it really talks about or includes the conditions in which people are born, live, work, learn, and grow, and ultimately age and die. It has to do with the economic environment around jobs and income, the built environment around housing and transportation and green space, education, access to early childhood education and high quality schools, the food environment, the community and social context, as well as the healthcare environment. And this is by no means a complete list. There's also important work looking at racism as a social determinant of health. And I actually was on the review committee for a National Academies of Science convening looking at immigration and immigration status as a social determinant of health. Before I go any further, I want to just pause for a second because we're going to be talking about disparities and health equity. And I want to make sure that when I use those words, you know what I mean, because the definitions have evolved over time and people have used them differently. And I primarily use the 2011 HHS definition that was used for Healthy People 2020, which defines a health disparity as a particular type of health difference closely linked with social, economic, and or environmental disadvantage. So again, differences that are linked with disadvantage that's tied with social determinants of health. And some people distinguish between a disparity and an inequity. It used to be that a disparity was just a difference, any kind of measurable difference, and an inequity was used more for those differences tied to disadvantage. I use them interchangeably to both mean differences that are linked with social, economic, and environmental disadvantage. The other thing that HHS did in 2011 was really broadened the umbrella in terms of its understanding and inclusion of groups that are included among those who experience disparities and inequities. Historically, most of the work looking at disparities was focused on low-income populations and racial and ethnic minority populations. As you can see by the list here, they included a range of other factors, including cognitive, sensory, or physical disabilities, sexual orientation, gender identity, geography, and other characteristics historically linked to discrimination or exclusion. In terms of defining health equity, I take the HHS definition as it was modified by one of my former colleagues at Morehouse School of Medicine, Kamara Jones, who defines health equity as assurance of the conditions for optimal health for everyone. It takes that public health assurance language, using that definition of public health as assurance of the conditions for people to be healthy, and really frames that around optimal health for everyone. And Dr. Jones includes 3 conditions for achieving health equity, which I think are important. One is that we value everyone equally, that we match resources to need, which means that those populations with the greatest need require the greatest resources, but that it also requires addressing both historical and contemporary injustices, that we can't pretend that the past didn't happen and that structures and systems driving inequities don't leave a powerful legacy, and that we need to address those as well as continuing injustices if our goal is to achieve health equity. Paula Braveman, another disparities equity scholar, talks about the importance of removing obstacles to health, such as poverty, discrimination, powerlessness, and a lack of access to the range of things that are included here. I don't know how many of you are familiar with the stream metaphor. You know, we in public health like to use the term upstream, but my anecdotal polling suggests that only about 2 out of 10 people using the term upstream actually know that it comes from this metaphor. And it really speaks to the idea that we spend a lot of time downstream, if you look on the right side of this slide, dealing with problems like mass incarceration or homelessness or infant and maternal mortality or untreated mental illness or chronic diseases, which if we had more meaningfully addressed midstream at the community level or upstream at the societal level, we'd be much more successful. And when we talk about social determinants of health, that's really what we're talking about, is moving upstream. And the story that comes from is that you had some folks standing by the stream and they saw people drowning going by, and they dove in and pulled them out, and dove in and pulled them out. And a prevention-oriented public health person said, "Why are all these people drowning in the stream?" And they walked upstream and they realized that people lived on one side of the stream, everything they needed was on the other side of the stream, and between those two sides was a rickety bridge. And then about every third person crossing the bridge fell in. So, they did what public health people do. They convened a task force. They met for 3 months. They had their proposals vetted and reviewed. And about 3 years later, they fixed the bridge. Pardon my sarcasm. We're much more efficient than that. But they recognized that had they understood what the root cause of the people drowning was in the first place and fixed the bridge so that there was easy access across the stream, people wouldn't be falling in, and we could reduce the need to pull them out of the water downstream by creating better conditions and policies and practices upstream. This is a framework that builds on that stream analogy by the Bay Area Regional Health Inequities Initiative, which is a great resource for information for those of you looking for more upstream approaches to addressing health inequities. And what this really identifies is that, historically, we in public health have been spending a lot of time downstream around educating people and interventions focused on individuals or case management or healthcare. And if we move more midstream and more upstream to thinking about what are the conditions people are living with that create opportunities for better health outcomes or barriers to those health outcomes, and what are the systems and structures upstream, both at the societal level and at the institutional and agency levels that create inequities where we're likely to be much more impactful and effective in moving the needle towards improving health and reducing health inequities. So where does this leave us? Where this leaves us is a recognition that the context in which people live is powerfully important. And while individually focused efforts and healthcare focused efforts are necessary, they're clearly not efficient and not sufficient. And if we really want to move the needle, then it means we really need to shift our focus away from health behaviors and away from healthcare, and to think about what the non-behavioral determinants and non-health sectors are that have the greatest impact. And that really means focusing on social determinants of health and focusing on the context in neighborhoods and communities where people either experience or don't those health opportunities. And that's really where the thinking has been around the importance of what's called health in all policies. And health in all policies is an approach to improving the health of populations by incorporating health considerations into decision-making across sectors and policy areas. Now, what that doesn't mean is that if you're thinking about the health implications for policy around housing or around education, that health becomes the most important consideration. But what it does mean is that you include health in those considerations. So just as an example, I had the opportunity a couple of years ago to testify before the Georgia legislature around housing policies and the fact that tenants had no rights in Georgia and the impact that had on educational and health outcomes in children. Was that the driving force for a decision to improve tenants' rights around housing? Absolutely not. But it provided a broader lens for legislators around the impact of a policy that ordinarily they might think of strictly through the framework of housing on other sectors in a way that I would like to think helped them decide to pass that legislation. You can see on the bottom that there's a host of ways to bring a health lens to policy decisions around green space, around transit, around affordable and quality housing, around a fair justice system, around universal design, around economic opportunities, and around food environments, and many more. What I'd like to do is just briefly talk through what some of those look like to give you a little bit more context. So education, as many of us know, really has a bidirectional relationship with health. Education is critical to providing life and health opportunities, primarily through the relationship between your educational attainment and your job opportunities and income, and what that does then in terms of positioning you for other social and psychological benefits, living in a healthy neighborhood. But health in school-age children is also critically important in terms of them experiencing success in educational context. And obviously, lots of contextual factors that impact on that. When you talk to a lot of people about the relationship between education and health, they'll tend to think about, well, what are they serving in the lunchroom? Is the food healthy? And are they getting any physical activity? And those are both important, but the most important thing about education is educational attainment. Are kids school ready when they start school? And are they successful in getting the education that they need? And we know what works. Everything from nurse-family partnership around parenting early on to center and family-based childcare, programs like Head Start and Early Head Start. There are high school completion programs, and even things like income and resource supplements, like earned income tax credits, have been demonstrated to have a powerful impact on educational attainment. For those interested, a lot of this work has been reviewed by the community guide that CDC does. They even have a health equity section of their systematic reviews that includes many of these. Housing also has a powerful impact on health, both in terms of quality, affordability, stability, and the context in which people live. We know that housing quality impacts both physical and behavioral health outcomes, asthma and lead being the two most prominent areas that have been looked at. Obviously, radon and its powerful impact on risk for lung cancer. Housing stability is tied to affordability. If you're having a problem paying your rent, that certainly doesn't stabilize your housing situation. And if your housing is not stable, it can undermine job security, it can undermine educational performance, and it can undermine your mental health. And last, both the community and the social environment significantly impact health outcomes, including social cohesion and social capital. Communities in which there are very high eviction rates that powerfully undermines that social and community cohesion. And it's not just one policy that drives these. And when we look at inequities, it's important to understand that it's a constellation of policies that has created challenges for communities disproportionately low income and disproportionately Black and brown. Transportation is another critical factor that can provide both opportunities and barriers to health outcomes. You may recognize Buford Highway on the left, those of you from the Atlanta area. Ironically, for many years, one of the areas with one of the highest traffic fatality rates in the country. Really a perfect stream analogy where people lived on one side of the highway, needed to go to the other side to get their needs met, with no traffic lights, no crosswalks, nothing to slow the speed of cars. But obviously, It's important for neighborhoods to have safe places for children and families to play and exercise, but exposure to toxins and pollution, also another powerful transportation-related factor. On the bottom right is an example of a complete street, which doesn't mean a street with a separated bike lane and a wide sidewalk, but it means a complete that's designed with input from the community that meets the needs of that community based on who lives there. So it may mean widened sidewalks with more frequent stops for public transportation if you have a older population or a large number of people living with physical disabilities, or it may mean one that looks like this, but it just depends on the nature of the community. Agriculture and food policy have a profound impact on health and life opportunities. We've gotten very good at the US at creating obesogenic environments, a combination of food deserts with barriers to access to affordable, healthy foods, and food swamps with high concentrations of both fast food and liquor stores. And again, there are policy solutions to address that, from zoning to alignment of farm policy with health policy, and to aligning of subsidies and incentives to promote local production and consumption of healthy foods. And the last example is climate change. There's been a lot of focus in public health on environmental justice, recognizing that low income and communities of color have had a disproportionate and unfair environmental burden. And people talk about cumulative impact, which is the intersection of environmental and social disadvantage. And it's critically important as we think about the impact of climate change going forward and how we mitigate that, that we think about those communities that are already experiencing the greatest social and environmental disadvantage, because they already are experiencing the greatest negative impacts of climate change. So some of this work is already going on. This was, those of you familiar with former CDC Director Tom Frieden's Health Impact Pyramid, a powerful recognition that social determinants of health on the bottom of the pyramid, that acting there is likely to have the greatest impact, and the greatest impact in a relatively short period of time. And you can see examples of some of the things and some of the things we've talked about around early childhood education, earned income tax credit, public transportation, but also at the community level, changing the context and opportunities to act there as well. And I just want to touch on what it means to bring a health equity lens. Bringing a health equity lens means intentionally asking which communities are the ones that are experiencing those greater social, economic, and environmental disadvantage. Which communities are already experiencing differences in outcomes and opportunities, and who is being left out or left behind, and what are the differential impacts of policy decisions. And bringing a health equity lens means not only asking these questions, but including those communities disproportionately impacted with both the sense making of what the problems are and the solution making of identifying how we solve these problems. And thinking about where the gaps are between resources and need, and how we can effectively target resources in a way that meaningfully respond to those communities being disproportionately impacted. So diversity, inclusion, and equity really need to be thought about both on the planning and understanding side and on the execution and implementation side. And it also means recognizing that we need to think more broadly about the goals and outcomes that need to be measured, and to ensure that those are meaningful to the communities that are being disproportionately impacted. And this is just one example. The HOPE initiative was a collaboration between Robert Wood Johnson Foundation and the National Collaborative for Health Equity, working to identify meaningful measurements based on existing data sets, both at the health outcome level and across different social determinants of health. And then this is just an example of what problem solving might look like if we're thinking not only at the health and social service level, but at the community level and upstream in terms of policies that either create conditions for health or create barriers to health and health inequities. And again, a lot of this work is going on, a lot of available resources in terms of the APHA, state level publications, work by the CDC, Trust for America's Health, Change Lab Solutions, which has been doing this work for a long time, and an organization called the Government Alliance for Race and Equity.